Good afternoon, everyone. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome to this first webinar in a series on transforming care for small and sick newborns. The series organized by the World Health Organization and UNICEF in collaboration with the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Today, I would like to remind you of a few house rules. You've seen you all muted so that our presenters today can go through the presentation without any interruptions. We ask you to not use your video cameras, please, and to type your question in the chat box, which is at the bottom right corner of your screen. You will have 3 presentations today that will last about 30 minutes, and then another 30 minutes for question and answers, where the question you type in the chat box will be read out to the speakers, who will answer as many as possible. If there are any questions that we don't have the time to answer, we will address them later on when we post this material online. Your facilitators today for this session is Tedbab Degefi Gabriel from UNICEF, where she's a senior advisor on maternal newborn health. She will introduce the speakers today and take you to this session. Tedbab, over to you.
The first webinar in the series. Our 3 esteemed presenters are Dr. Lily Kak, who is a team lead for newborn health at USAID Washington, and Ms. Silke Mader, an affected mother and chairwoman of the executive board and co-founder of the European Foundation for the Care of Newborn Infants and the new initiative, the Global Alliance for Newborn Care, and Dr. Ornella Lincento, a senior medical officer at WHO headquarters Geneva. In this first webinar, UNICEF and WHO, with the support from partners including USAID, Every Preemie Scale, Save the Children, London School of Hygiene, Tropical and Medicine, and the Gates Foundation have collaborated on a technical report focusing on small and sick newborns. Survive and Thrive, Transforming Care for Every Small and Sick Newborn outlines the global problem, showcases the progress, summarizes what can be done to transform inpatient care for small and sick newborns, and demonstrates the importance of data to guide investment and improve quality and equity. It presents a clear call to action to accelerate progress toward the Sustainable Development Goals to ensure every newborn has the chance for to live a healthy and productive life. The report includes 6 technical chapters with contributions from 94 authors who came from 16 countries and had 40 institutional affiliations. Now to the first presentation, Dr. Lily Kak.
Good morning, good afternoon, and good evening, wherever you are in this world. The main takeaway messages from this webinar is that the global community needs to expand their focus from strengthening essential newborn care for all newborns to include strengthening special care for the most vulnerable newborns, the small and the sick ones. In this presentation, we will focus on the key messages of the first chapter. This includes showing the link with the key global strategies and frameworks, such as the Convention on the Rights of the Child, presenting the importance of family-centered care, and finally, showing how we have learned lessons from our past. This graph shows the projected neonatal mortality of each region if progress were to continue on the current trajectory. What we see is that newborn mortality is reducing too slowly at the current rate of decline for countries to meet the SDG target for newborn mortality of at least 12 deaths per 1,000 live births by 2030, which is shown by the blue star in this graph. As you can see at the current rate, it will take a century before a newborn that is born in sub-Saharan Africa who will have the same chance of survival as a newborn born in Northern America, Europe, or Australia today. About 40 countries will need to double current progress to meet the goal. Many others will have to close the equity gap in their countries. There are many myths about small and sick newborn care. We are highlighting just a few in this presentation. Here is the first myth. There is a common myth that we will achieve the 2030 SDG goal of 12 newborn deaths per 1,000 live births if we just roll out essential newborn care. But the fact is that extensive extra measures are needed to achieve the target in all settings. These include effective high coverage of antenatal care, essential childbirth and newborn care, postnatal care, as well as inpatient care for small and sick newborns. This report shows that we will not meet the SDGs unless we transform care for every newborn, including the most vulnerable, the small and sick. So who are the most vulnerable newborns? From a clinical perspective, this includes newborns who are born too soon or preterm, too small or low birth weight, or acutely ill. From a public health perspective, newborns most likely to die include those born small and sick in the most marginalized groups, rural areas, urban slum environments, and humanitarian settings. Added susceptibility may result from factors such as poverty, ethnicity, gender bias, maternal age and educational status, disability, and low literacy of the caregiver. Vulnerability is most acute in low and middle income countries where health systems face specific challenges. Here's another myth. There is a myth that we need to focus more at the community level, not the hospital level, to meet the SDG target. The truth, however, is that globally, 80% of births now take place in facilities, and community care is more effective when linked to care in health facilities. We recognize that a number of key global initiatives have contributed to the considerable strides made to improve maternal, newborn, and child health during the last 2 decades. Chief among these are the Millennium Development Goals, Sustainable Development Goals, the Global Strategy for Women's, Children, and Adolescent Health, and the Principles of Universal Health Coverage. These strategies are guided by the Convention on the Rights of the Child, the Safe Motherhood Initiative, the Every Newborn Action Plan that was launched in 2014, the Continuum of Care Framework, and the WHO Framework on Integrated People-Centered Health Services. All of these are important and described in the report. We're going to briefly discuss 4 of these initiatives and framework. First of all, newborn health is a human rights issue. Articles 6 and 24 of the Convention of the Rights of the Child emphasizes the right of every newborn to the highest attainable standard of health and health care. Professional associations and other expert bodies have also defined and described newborn health as a right, such as the Parma Charter and the Abu Dhabi Declaration. These declarations call for rights such as survival, health, and development, legal identity from birth, protection from harm, violence, and neglect, caring, loving, nurturing environment, even in humanitarian and fragile settings. Unfortunately, these rights are not respected or protected in all settings, particularly for the most vulnerable newborns. And it is important that countries translate these rights into domestic laws and regulations and incorporate them into protocols and guidelines for newborn care. The second major global initiative to reflect on is the Sustainable Development Goals. For the report, we conducted a mapping exercise of the 17 SDGs to newborn care in order to show the important links to broader development issues. The mapping reveals a strong connection to 14 targets within 8 SDGs. Improving small and sick newborn care will do more than help us meet the specific health target for newborn mortality. It will support efforts on goals relating to poverty, hunger, health, education, gender equality, and clean water and sanitation. The third item to draw attention to from the report is the continuum of care concept. This figure presents the basic health packages across the continuum at different levels within the health system. Interventions with the most benefit for small and sick newborn care can be integrated at different points in the continuum. The highlighted section shows the levels and packages of care that we focus on in this report for inpatient care of small and sick newborns. While this framework focuses on the intervention packages, we recognize that the way in which the package is delivered is just as important as the content of the package. According to the Lancet Global Health Commission on High Quality Systems, an estimated 61% of neonatal deaths can be averted with good quality care. It should also be noted that small and sick newborn care programs need to integrate compassionate and nurturing care excuse me, in the first 1,000 days, from pregnancy to 3 years of age, to prevent developmental delays and physical disabilities. I'm going to hand over the presentation now to my colleague, Silke Matter. Silke, over to you.
Thank you very much. Do you hear me now?
Yes.
Yes, thank you. Hello to everybody. It's for me as a patient representative, of course, very special to have the honor to speak today to you. So finally, we wanted to show you also the WHO framework for integrated people-centered healthcare services. This framework has adopted by the World Health Assembly in 2016 and focuses on 5 interdependent strategies for integrated and people-centered care. These strategies are listed on the slide here, and importantly, it recognizes the need to empower and engage informal caregivers with family members and others who play a critical role in healthcare. There needs to be greater alignment across health services, communities and policies to enable and support healthcare providers, community health workers, and people to work together. In this report, the person at the center, so the blue balloon you see in the middle of this figure, is a vulnerable and sick or preterm newborn. Often it is the mother and the newborn as a unit, but not always. So to ensure application of people-centered care for small and sick newborns, an approach is needed to maximize the role of the parents and family members while the newborn is cared for in a health facility. For us patients and parents, it's of course also very important that a good discharge management and follow-up is provided. All of this is named family-centered care. Next slide, please. Family-centered care promotes a mutual beneficial partnership among parents, families, and healthcare providers for patients of all ages with an aim to support healthcare planning, delivery, and evaluation. You see here also the topics of the principles, the dignity and the respect to the patient and also the family members, the information we need to get from the healthcare professionals so that information is provided, participation in an active role, and the collaboration. In relation to newborn care, a family-centered care approach encourages mothers, fathers, or caregivers to be active partner in the child's care. The parent and the newborn are a unit of care which is central to the newborn's well-being and development. Family-centered care for newborn health has a growing evidence base and has demonstrated benefits for infants, for example, weight gain or developmental progress, as well as decreased parental stress and anxiety and increased caregiving efficiency. Some trials and testing comprehensive family-centered care approaches in the last years, and they have taken place across various settings, including China, Canada, Australia, the United States of America, and India. And I will show you later also a good example from India. Next, please. There are, of course, also myths and facts. And one of the myths we see quite a lot is that people think that allowing parents and family members to visit their child in a NICU will introduce infections. And we can see this very, very sadly at the moment at the COVID-19 situation, that parents are excluded in many, many hospital settings and have no access to their baby, and in some units only for 5 minutes or even only half an hour per week. This is really something we have to discuss also later, but have to have in mind that this has a long-term consequence if we really continuously treat our babies in the COVID situation like this. Fact is that family-centered care does not increase infections. To prevent infection with hand hygiene practices and to access human milk will in the end support and also prevent this kind of infections. Next slide, please. As mentioned before, in our chapter includes case studies, and one of them is this from India, using the family-centered care approach. This has now been established as a national program and has led to a profound shift in the treatment of sick newborns in India. The slide shows the timeline of scale-up from an initial program at one hospital, which conducted a random control trial showing benefits to breastfeed and no hospital-acquired infection or adverse events. This was then scaled up in 85 districts with demonstrated impact on the health and the mortality, which then led to the development of a national policy to scale up the family participatory care approach. Here I would like to thank especially Professor Atimaria and her colleagues and the team to establish this really wonderful project. And you can see here very well how family-centered care can change the outcome of the children. Next slide, please. Parents are really powerful agents of change, as has been demonstrated historically in the care of small and sick newborns. For example, parents successfully lobbied for family-friendly hospital changes, for implementing discharge or follow-up systems, or also for pain management for preterm infants. Parents also become patient experts with a deep knowledge of the health issues relating to their child. This results in them becoming a asset to the broader healthcare system, serving as advisors to hospitals, other parents, or even policymakers. Parent advocacy and support organizations often emerge spontaneously when affected parents decide to raise awareness and share their experience to help others in the same situation. Some examples you can see here is from Colombia or France, where these parent organizations have coordinated parent voices and also collaborated with healthcare professionals together to develop policy recommendations or even to change systems in the different hospitals. Next slide. Here I would like to share with you my own personal story. I'm a mom, I'm an affected mom of twins born 1997, and my children were born with 515 grams. You see here Lucas, and Lena was born with 290 grams, and she passed away only after 1 week. I live in Germany, in Munich, and many people will think, well, a very well-developed country, so what should be the problem? We had visiting hours, only 3 hours per day, We had only this chair you can see here where I'm sitting on, and this chair I had to share with all the other parents in the unit at this time. I lost all my breast milk because I had no support. There was no lactation consultant, there was no psychologist, and there was nobody who helped me at discharge or even at home when we were after 4.5 months discharged, and I was lost with all my emotions and lost in the end with all the support I would need it at this time. Next slide, please. And what I have done afterwards is, of course, I was full of anger and emotions in the very first weeks and months. But I thought, as I mentioned before, I have to do something and I have to change it for the next generation of parents of preemies. So I have built up in the very beginning a self-help group in Munich, was 8 years the president of the parent organization in Germany. I changed 3 laws in my time frame there. And then I saw we have to do something on a global or a European setting. I founded EFCNI, the European Foundation for the Care of Newborn Infants, and I put all my effort inside to build up a voice for us as a parent, but maybe later also for the preterm babies themselves. So what we are doing is we meet every year once and bring all these parent organizations together. We help each other in learning from each other, but also supporting from each other, and provide all our materials and trainings in several languages. We have developed strategies to get a voice, like EFCNI, together with other parent organizations, initiated World Prematurity Day on November 17. We have built up a European standard of care for newborn health program to implement really the best practice in care for our children, together with more than 190 experts from all over the globe. And last year, very proudly, we founded GLANCE, the global initiative of parents to get a global network. And our aim is that we have till 2040 in each country of the world a parent initiative and a voice of themselves. And when you look at this picture, and I'm this blonde lady in the first row, next to me is a young boy, a young son, my young son, Lucas, and he is now 23 years old, and he, together with another post-preterm infant, joins in the meanwhile this initiative because we speak for ourselves as the parents, but we need also a voice for our preterm babies themselves, who are now young adults. So they are now able to speak for themselves, to improve the care for us, for parents, and for the children themselves. Thank you very much. And I would then hand over to Lily Kack again.
Thank you, Silke. And thank you so much for being such a wonderful agent of change. You are truly inspirational. So in this last section of the presentation, we're going to look at what lessons can we learn from countries that have substantially reduced their neonatal mortality. I'd like to pause here and take a good look at this slide. This graphic depicts a transition model of newborn care. It shows that the United Kingdom and the USA achieved dramatic declines in neonatal mortality rates across 3 phases, shown here in 3 colors. Shown in blue, phase 1 saw a decline in neonatal mortality by 25% in the early 1900s and was characterized by broad public health approaches, including hand washing, an increase in skilled birth attendants and physicians, and the role of parents as primary caregivers. Shown in orange, phase 2 saw a relative decline in NMR by 50% in the mid-1900s and was characterized by a shift towards individualized special care of sick newborns, but also the emergence of some harmful practices such as overuse of technology and separation of newborns from parents. Finally, phase 3, shown in green, saw a relative mortality decline by 75% and is characterized by high-quality intensive neonatal care provided within strong health systems by skilled specialists, and where family-centered nurturing care focusing on disability-free survival is a best practice. What we have learned is that changes across all three phases are required in order to achieve the SDG target for newborns to survive and thrive. Today, many countries have implemented these components depending upon which phase they are in. Health policy experts and practitioners should first identify their country's starting point and priorities, and then determine which lessons can be applied to improve special and intensive care, and consider how to integrate a family-centered care approach. This phasing approach is used throughout the report, and it is important to grasp that this builds from a historical analysis of lessons learned. In summary, some overarching messages on what we learned from the past include: routine separation puts mothers and newborns at risk for medical and developmental complications, regardless of setting or level of care. Essential newborn care is not sufficient to achieve the SDGs. We need rapid scale-up of family-centered care, special and intensive newborn care that focus on disability-free survival, competent and equipped health providers. This report shows that transforming care for small and sick newborns will mitigate intergenerational poverty and strengthen each nation's human capital. As noted earlier, this is the first of a series of webinars. Future webinars will show what is required to do this, including understanding the burden and where to target investments, the importance of delivering quality of care at scale, how we can ensure nurturing and responsive healthcare that is designed to prevent disabilities, support cognitive function, and promote nurturing newborn care to support early childhood development and reduce stunted growth. What data we have and what data we need to monitor progress. And finally, what actions are needed to save more than 1.7 million newborns each year. Now, to be very relevant to the current pandemic situation, we did add a few slides on the COVID situation and how it impacts newborn care. And I'm going to go over Ornella from WHO to take over at this point. Thank you. Ornella, over to you.
Thank you, Lily. Thank you very much. So we are all facing an unprecedented challenge with this COVID-19 epidemic. And actually, both personally, I think, and professionally, and all over the world. So this is why we thought it was important to not to this where we are, and so the present, and to include a couple of slides that are looking at how the COVID-19 impacts on neonatal health and also on the expansion of the services that we are aiming to achieve by 2030. So the first two slides, the first is on really on the impact of COVID-19, and that we are actually we are already that COVID-19 response is impacting on availability, on accessibility and quality of care services, both for pregnant women as well as for newborns. And while we don't know what will be the full impact on maternal newborn health, we by the end of the pandemic, we already know that it's not more the direct impact, it's more the indirect effect that we are having, because we are lucky that the virus is not affecting very much, it's not affecting more pregnant women than the general population. And it also doesn't seem to affect very much the newborn compared with the other ages. However, we are very concerned about the decline, the potential decline on coverage of services, both because people might fear to access services or because actually services are not available because of the restriction or for repurposing some of the services. So modeling that are going on and we are continuously adjusting are showing that, for example, with a modest decline of only 10% in coverage of the services, we might have a pregnancy-related and newborn and childbirth services. We can have an additional 28,000 maternal deaths and 168,000 newborn deaths. You can imagine if the decline becomes even bigger. But WHO is looking at what are the essential services, and actually we have already defined that maternal newborn health services, including small and sick newborn care services, remain core essential service during the pandemic, meaning that they need to be protected, they need to be promoted, they need to be adjusted in order to not to have a reduction in coverage and not to have a reduction in quality. Next. And then the second slide is more, I selected more to few recommendations basically on that are relevant for newborn health in case the mother has suspected, probable or confirmed COVID-19 infection. I selected this because I hear from countries concerns regarding keeping mothers and babies together, even a healthy mother, not saying mothers with the COVID, but even healthy mothers in some countries are separated or are not allowed to breastfeed. So it's really concerning for us. And so if the mother has suspected, probable, confirmed COVID infection, actually we don't have evidence of vertical transmission of COVID-19. And even the few babies who have experienced COVID-19, the majority of the few had, seems to have been infected after, in the postnatal period or not during pregnancy. And in any case, either they are asymptomatic or they have a very mild illness. So it's not a big concern from that point of view. So in practice, we recommend that the mothers and infants should be able to remain together. Even if the mother is positive, they can practice skin-to-skin contact in the delivery room as well as later on if the baby is preterm. So kangaroo mother care and rubining day and night are encouraged, especially during the establishment of breastfeeding. This is why this? Because the benefits of breastfeeding, the benefits of skin to skin, the benefits on much higher than the risk of COVID in this population group. Then in the case the newborn is for some high risk condition, preterm, so illness is admitted in the neonatal units, also mothers should be supported if positive to express breast milk. And the unit should have in place arrangements for the mothers to have access to the unit and to their babies. So of course, for all that to be safe, appropriate infection prevention measures should be applied. So for the mother means wearing a mask and practice respiratory hand hygiene. And for the health facility, of course, it means to have, washing, IPC, and also isolation rooms in place. So that is from my side, and I want to anticipate that in each of our series of webinars, we will include 2 slides on COVID, which will highlight the key information, the evidence, as it will be made available, of course, for issues that are related to neonatal care. So next slide, and I think we are near the closing. Yes, so many partners you can see in these slides contributed to the WHO and UNICEF report, Survive and Thrive, Transforming Care for a Very Small and Sick Newborn. And we are, and with them, we are working for the implementation of the recommendation of the report. But I am also trust that all of them will support us in ensuring that the essential services for newborns are kept, are in place, even during the critical time of the pandemic of COVID-19. Thank you very much.
Thank you very, very much to all our three presenters. We now have 25 minutes to take your question which you type in the chat box and for the presenters to answer them. I will start reading out the question. Keep typing if you have more questions. And Zilke and Lily and Onela, you are on mute as well, so you need to unmute yourself to answer the question. We have a question from Harish Kumar on asking what the recommendations are for KMC if mothers are coronavirus positive and the baby is not.
Is a question?
Yes.
If the
recommendation for corona positive mother.
If the mother is positive and the baby is not, what is the management for the mother?
Yes.
If she is sick, I mean, it's the same management that we have for the general population with COVID. So if she is asymptomatic, or with a pouch symptomatic, she can stay at home. I mean, she delivers in the health facility, of course, if possible, and or if she delivers at home, she delivers with a skilled birth attendant, a midwife. And then she has to be isolated as any other person with the COVID, positive for COVID. If she is symptomatic and very sick, you know, it depends on how sick she is. Of course, she needs to have care for COVID. So if she's very sick, she might even go in a special, you know, in a special department for people with COVID. But if she's not very sick, she can be also isolated in the postnatal ward or whatever. And in this case, however, we need to put in place, I mean, isolation means distancing. If it's not possible to have full room total isolated, means that she has to wear a mask also. She has to practice hygiene, hand hygiene, and for breastfeeding. She is allowed to breastfeed, but she has to practice hand hygiene much more than in other cases. And then what else? The mask is important, and the same is for healthcare providers. They have to wear protective equipment in caring for the woman. If she is at home, also she has the provider, the people in the family. I mean, she has to differentiate from the people possibly staying in a separate room with their baby and then the other family members. And similar, same recommendation than for the general population. The only difference is that mother and baby, of course, they cannot do social distance, no, because for breastfeeding you can you have to be closer than 1 meter, and so this is why we recommend for the mom to wear the mask.
Thank you. That answered a follow-up email by Evelyn Zimba on nursing mothers who had contracted the coronavirus. Another question, two other questions actually on family-centered care. One also from Harish Kumar asking what the challenges are in implementing family-centered care besides infrastructural issues. Did you hear the question?
Is for whom? For me?
It could be for Lily.
Well, yeah, this is Lily here. Let me start responding to the question, and maybe Silka and Ornella might also want to chime in. As to me, the biggest challenge is really the structure in the hospital, you know, the changing the health system in the hospital that actually enables the family-centered care approach. There are lots of, you know, there are perceptions among health providers that may not be supportive of family-centered care. So the behavior and the perceptions of health providers themselves need to change. The health system and the way the space, the structuring within the health system, the hospital itself also needs to change. So I believe those would be the biggest challenges that would face countries as they begin to introduce family-centered care approach. Silka and Ornella, do you have anything else to add?
Yes, I can only add that it is mainly a change of mind. It is to come for a visiting, I would say, idea to a welcoming policy. So to really involve the parents as the main caregiver, to give them a feeling of that they are welcomed. And if we are able and open in the end our hospital settings, it needs, as you said, Lily, also the facilities, but also something like provide food or providing something to eat or drink, or if it is not possible to provide it, to give them space and opportunity that they can provide their meals themselves. But these are all, I would say, structure issues, but the biggest change is needed in changing the mind of the people in the hospital settings. The parents are very important and are the main caregiver, and that this baby is going home with the children, with the family, and therefore the parents need to be self-confident in the end to bring this baby home and also to give them a good start in life at home.
Yeah, I fully agree. I think I would add that there is a change of mind that has to be global or universal, and has to be from the side of the care providers as well as on the side of the parents as well. I mean, in many countries, parents are not demanding. And I think we have to help them also to get empowered and demand a change. You know, is for us working as I work in many different type of countries, and I know how challenging is to advocate and to get resources for newborn babies. Is really, really difficult. So I think we need to join hands with the parents, with the population, with the community, with our peers, professional organization, etc., for demanding this change, the transformation actually that we are promoting through the report. And I have to say, if this transformation would have been already in place, we would not have been discussing now these challenges with the COVID-19, probably, because the washing facility would have been better than it is. Some more space for separating, for isolation would be in place. There would not be challenges in terms of breastfeeding and so on. So I think we have to work a lot and joining hands to make these transformations really possible and stable.
There are more questions on parent-centered care for all panelists, really, from Nina Katka, who said that the graphic you share on parent-centered care was excellent and useful. She wondered if it's possible for you as panelists to share your views on how PCC contributes to nurturing care and quality of care. Is there a schematic somewhere that they can use? That would be useful for country to take this concept and translate them into program and measures to demonstrate progress.
Yeah, thank you for that question. I think you know that is my favorite topic these days, the family-centered care and how nurturing that can be for the newborn, and how important that is for the neurodevelopment of the baby. So I would actually want to sort of draw the participants' attention to the webinar on Chapter 4, which will be presented by experts on June 17th. That chapter is called Ensure They Thrive. So it's all about family-centered care. Well, some of it is about family-centered care. And that's where the conceptual framework that Nina referred to will be presented. Basically, the conceptual framework includes, I think for me, the conceptual framework has been very useful. It sort of, in a very concrete way, it it helps us operationalize nurturing care. And it includes some domains such as good nutrition. It includes skin-to-skin care, particularly kangaroo mother care. It includes pain management and responsive care, and so on, and positioning of the baby. So very, very concrete interventions that can be bundled together to make the care much more nurturing, because it's providing a very supportive sensory environment for the baby to ensure that it thrives. So I encourage you to join in. Of course, every webinar, every 2 weeks, we're going to have a webinar for every chapter. But this particular one on June 17th will address this issue a bit more in detail. Thank you.
Thank you. We have a comment, another question from Dansgudova-Nikovska, saying that in a country, North Macedonia, there is a lack of data on perinatal mortality, and that the first mortality audit ever was supported by UNICEF and gave them insight into the reason for mortality and finally triggered action by the government. Do you have anything to say about data? I know there is also a webinar on that specific topic very soon, in 2 weeks.
Yes, data has always, it has been a problem in the field of newborn health, and we are really trying to do a better job of it. And actually we are, I think. We do have some data specialists and all that working on the prevalence of, small and sick newborn care and what the needs are and so on. So there will be on May 20th, I'd like to draw your attention to chapter 2, and it says what the numbers say on May 20th. I would encourage you to attend that and raise that question again, because you will have experts on numbers in that particular webinar. So, and I'm glad you noticed that as a major need in your country. Please do advocate for it. That's all I can say at this time. It is important what the prevalence is before we...
and maybe to complement, there will be also a webinar near the end, because we have also a chapter on the values of monitoring, more on the health information system, the data more, not the epidemiological data that we will describe in the chapter, in the next webinar, but on the systems which kind of data and how to strengthen the systems for getting better data and use the data for programs. This will be in July.
Yes, I will type in the chat box a link to the list of all the webinar series and the dates. Another question from Yenelalem Tadesse Woldemariam on NICUs in developing countries being already overcrowded and understaffed, which affect the quality of care. So how does the statement saying that family should visit not lead to more infection in these cases when you have already overcrowded and understaffed units?
Well, that is why we are developing standards, and why we are, and I think we have to really go back and look at what are the minimal requirements and the minimal standards that we have to have in place in order to ensure the survival and the well-being of the babies, as well as their mothers and families. And I'm aware that they are overcrowded, the neonatal units in some countries. In other countries, they are not overcrowded, but at the same time, the quality remains poor, because even if the mother is there, she's not supported. But, I think there is, this is why we are discussing these issues, and we need really to advocate for having more resources. And resources means everything. I mean, it means infrastructure, equipment, supplies, space, and policies, human resources that really make possible to have decent quality services for every newborn who needs them. So, yeah.
Thank you, Ornella. We have a question for Silke about thanking her for a very inspiring presentation and your achievement. And Helen Nabuera asked her how you ensure equity of participation in GLANS, such as resource-limited settings, more educated mother, maybe more able to engage with international groups versus the less literate mothers. So how do you bridge that equity gap?
That is a very good question. So what we tried in the very beginning as we started EFCNI to also here we have these differences between Western European countries and Eastern European countries. And of course, it was sometimes a challenge to, first of all, to understand what the challenges are and also to, in the end, help and engage and support this organization. Now on a global setting, it is, of course, a much bigger challenge, first of all, to understand what are the different needs in the different countries. And what we try is that we find parents or patient representatives in the different countries. And when you see on our history that only in 10 years, we could establish more than 100 parent organizations across the world and establish also the World Prematurity Day and many other projects, it is really the power behind of these parents. And what we are looking or hoping also from healthcare professionals across the world, that they help us to identify parents. And what we have done, for example, in Africa is to support our parent organization in Ghana, who started an African organization. And now together with Selina Bentham, we are working now to have in each of these African countries an own organization that also they can help each other. What we are doing is providing support and training. They are coming once a year to us to Munich. What we are doing is we're supporting them with bringing them over. That means we are covering the hotel and the stay for this training and meeting. We are training them and giving mentor support for the different organizations to get a hand how to establish this, to learn from each other so that they really can start with a national voice in the country. This is what we can do. We are not supporting or not able at the moment to support the organizations with funding, but we can help with network and with tools or templates or blueprints to make things faster. And we also collaborate then with the WHO and other NGO organizations to make things in the end more sustainable. The challenge what we are facing is that we to find a parent representative who is able to speak English, so that we in the end have someone who brings this knowledge what we develop on a global level of patient organizations to the different countries. But we were already successful in the last year of having already in three countries in Africa, for example, having there an organization. Where we are really lacking, to be very honest, is in Asia. So we hope with this initiative also we will find patients who are able to help us to establish something. So that's, I hope I could answer your question on this a little bit.
Thank you very much, Silke. We have a question on separation, with several people saying that there are many reports of baby being completely separated from the mother because of COVID. Do you want to talk about that, about separation mother of babies, and the recommendation about no separation?
Is for me this question?
You can take it. Yes, Onela, go ahead.
Yeah, but what is actually the question? We recommend no separation, yes. So
it was a comment saying there's a lot of report of mother and newborns being separated, in fact, because of COVID.
yeah, there is a lot of unnecessary separation, let's say, that we know we have been alerted. We have tried to respond to this by being more clear with our recommendations. We have published on 28th of April questions and answers for care providers as well as for parents on these issues related to no separation and breastfeeding in the context of COVID. And so we hope that people will be reassured that no separation is possible. First of all, it's very recommended for all women, but it's also not particularly dangerous for in case the woman is positive. It's not dangerous for the baby. I mean, we don't have reports of babies died because of no separation. And even so. And
yeah, this is Lily
the
here.
benefits, as I said before, the benefits of breastfeeding and no separation are much higher than the harms. So of the harms of the COVID infection, in case the no separation causes infection in the baby, because babies, if infected, first of all, there are very few who are getting infected, but also they are experiencing infection or no symptoms at all. So, yeah.
This is Lily here. I just want to add that the at the global level are so new, and the evidence, we're learning every day in a very rapid pace. So because the recommendations are new, it's possible that the recommendations are not trickling down to the facility level and of course to the community level. So we would ask you as champions and experts in your countries to please get familiar with the WHO recommendations and make sure that they are being shared widely through your networks as well. We need everybody to get on board. Thank you.
Thank you. And the last question, and that again is for all panelists, from Eunice Moussema Abdella, asking that when you talk about the care for small and sick newborn with a passion-centered approach, do you have any experience about LMIC and how they tackle the lack of adequate wash infrastructure in health facility to be actually able to provide quality care for the newborns?
Yes, so there are the numerous countries that are putting in place approaches that facilitate non-separation. First of all the countries around the world that are implementing kangaroo mother care. So this is for small and sick premature babies and also not sick, just premature. And there are many countries that are doing this and are moving from kangaroo mother care when the baby is stabilized to really very early kangaroo mother care. To countries that are starting in implementation of no separation policies from birth, basically. So, and then of course for the normal babies, there are so it doesn't take more space to keep the mother and the baby together in the delivery room or in the postnatal ward. The challenge is when the baby is sick, because many neonatal units are organized with limited space, but countries are also opening kangaroo mother care rooms where mother stays with their babies, and it doesn't take extra space, because by doing that they make free some of the incubators, the infrastructure for the most severe babies. So yeah,
thank you. Thank you, Ornella. And it's time to close this session before I hand over to Tidbab to close it. I just want to answer several questions that yes, we will share the recording of this session as well as all the presentation on the qualityofcarenetwork.org website, and send you a link to this posting so you can access it as soon as it's ready. Tidbab, over to you to close now.
Okay, thank you, Benny, for this excellent moderation. And also I thank Lily, Silke, and Ornella for really expanding on this report and highlighting the key points and the takeaway messages. As you see on our closing slide, this report is about transforming care for every small and sick newborn. And as we have discussed, the transformation requires a significant investment in human resource, in developing standards and guidelines, and making sure that those guidelines are translated into human-centered services. And we have also discussed, how this will affect the current context affecting this care. As Benny mentioned in her closing, this website, this webinar is recorded and it will be posted. So we encourage you to share to colleagues who are not able to join this, and also for your further reference. And also, again, I would like you to invite you for the second webinar that is coming on the data. You will not want to miss that. It will be on May 20. And thank you for the lively discussion and for spending your time with us today. So back to you, Benny, to close it.
Thank you, everyone. Thank you for your time today, and we will send you the background material. Have a wonderful day or evening. Bye.
Thank you. Bye.
Thank you.
Thank you. Bye. Bye-bye.
Bye.